So in this video I'm going to be discussing the ankle joint. So first, to do an assessment of the ankle, you're going to do an observation, so looking at the ankle from all four angles. So you're looking for any bruising, contusions, any laceration, any swelling, any scar formation. I'm going to be looking for any calcaneovirus or calcaneovarus, and you're going to look at the height of the arches for any pes planus or pes cavus. In cases of pes cavus, a neurological condition could be possible, so that should be an automatic referral. Then what you're going to do is have a look for the gait. So if I can just get you to walk forward for me, please. So you look at the gait cycle, looking for ease of movement of the foot and the ankle, and equal plantar flexion and dorsiflexion. Then what I'm going to do is I'm going to get you to do some active movements for me. So if you could first of all just pick up your foot, and then if you could just bring your foot up for the ceiling for me, perfect. So that would be dorsiflexion, and then bring your foot down, and that's plantar flexion, perfect. And if you could just do that with the other ankle for me, that's dorsiflexion, and then down to ground, plantar flexion. Okay, you've got other movements as well, but they tend to come from the subtalar joint or the feet, so inversion and eversion come from the subtalar joint. Okay, and now with the patient in a supine position, I'm going to be looking for passive movements of the ankle. So I'm going to compare the good side to the bad side. So first of all, I'm going to have a look at ankle dorsiflexion, and then ankle plantar flexion. And as I said before, eversion and inversion and eversion occur at the subtalar joint, but just to illustrate there for you. Okay, so what I'm going to do first of all, I'm just going to use this ankle as an example, is I'm going to do the palpation routine. So I'm going to feel down the lateral aspect of the fibula and down the lateral aspect of the tibia. I'm going to feel between them for the inferior tibiofibular joint, and the tibia and fibula are connected with an interosseous membrane. Okay, and then I'm coming up to the lateral malleolus, which is formed from the fibula, and the medial malleolus from the tibia. And what I'm going to palpate is the talus, and the head of the talus, which is slightly medially, as it goes through the mortise provided by the inferior tibiofibular surface. Okay, and then as I come off from the head of the talus, you can feel the navicular, and then going down into the sustentaculum tali of the calcaneus, and the calcaneus there. So the sustentaculum tali is the attachment of the spring ligament Okay, and come up for the medial tubercle of the talus there, which is attachment of the medial collateral ligament. Okay, then laterally, from the lateral malleolus, you have the peroneal tubercle, which separates the tendons of peroneus brevis and peroneus longus, and you have the sinus tarsi, which transmits extensor digitorum brevis, contains the fat pad, and also the anterior talofibular ligament. Okay, so if we were going to move on to the soft tissue ligament, as I said before, you've got the spring ligament, which goes from the sustentaculum tali of the calcaneus to the navicular there. And you've got your medial collateral or deltoid ligament, which is formed of your anterior tibio-talar ligament, which comes up through here. You've got your posterior tibio-talar ligament, your tibio-navicular ligament, and your tibiocalcaneal ligament. And posteriorly, you've got your Achilles tendon coming in to insert onto the calcaneus. You can get tendon osteophyte growth there. You can get march fractures as well on the posterior aspect of the calcaneus. An Achilles tendon is formed as a common tendon formed from the tendons of gastrocnemius, soleus and plantaris. Then if we're looking on the lateral aspect, you've got the lateral collateral ligament, which is the ligament most commonly injured in inversion strain, which is the most common injury at the ankle. So first of all, you have your anterior talofibular ligament here, which is the most commonly injured ligament, and sometimes you can tell if a strain has occurred because you get an egg-shaped swelling over that anterior talofibular ligament. Then you have your calcaneofibular ligament and your posterior talofibular ligament. Okay, and coming around here, you've got your peroneals, so if I can get you to resisted eversion to palpate through there. Okay, then if I was to go back to the medial aspect, you've got the tendons of tibialis posterior, flexor digitorum, so if you just push your feet up for me in there, perfect. You've got your posterior tibial artery, so you feel the pulse. Now, 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 and you're looking for rate, rhythm and amplitude. You've got your tibial nerve, if you just bring your pressure big toe up for me, and then you've got the tendon of flexor hallucis longus. Okay, so special testing, and then I can first of all do a general anterior draw test, which is looking for any instability of the ankle. So take the ankle into slight plantar flexion and bring the calcaneus and the talus forward on the inferior tibiofibular joint, looking for pain and an increase in gapping. Then what you can do to test for the anterior talofibular ligament is to look at plantar flexion and inversion, and you're looking for an increase in pain. You're putting some stretch through the ligament or any instability. Then if you want to test the anterior talofibular ligament and the calcaneofibular ligament together, you can just do inversion without the plantar flexion. You're looking for any increased instability or localized pain. Finally, if I wanted to look at the deltoid ligament, for the integrity of the deltoid ligament, I could just apply an eversion strain, looking for increased gapping, pain or crepitus, and obviously testing with the good side to see if any is present. Okay.